Welcome to CVPR 602, Blood Coagulation and Hemostasis. Today's screencast is on heparin alternatives for cardiopulmonary bypass. Heparin has so many advantages to any alternatives that are out there. And so let's review some of the clear advantages that heparin has for use in extracorporeal circulation. Its effectiveness occurs immediately. 3 minutes after we bolus, we can test and we can see a result. It's a very fast-acting drug. It's highly effective at preventing thrombosis. It's rare that we see clot formation in our venous reservoirs and in our circuits when we run our ACTs above 480 seconds. The monitoring is very simple and rapid. As with point-of-care testing, we can measure an ACT. We can also measure heparin levels or a combination of both right at the pump side. Also, when we are finished with surgery and the cannulas come out, it is easily and rapidly neutralized with protamine sulfate. And so the single most cumbersome aspect of heparin alternatives is the inability to rapidly reverse anticoagulation after weaning from CPB. Nearly all heparin alternatives, there is no reversal agent equivalent to protamine. That's a very important point as we discuss some of the alternatives that we could use if we could not use heparin. And remember, the reason we can't use heparin is almost always because of an immune-mediated response like heparin-induced thrombocytopenia. So this is a great paper, this clinical practice guidelines. It's on Blackboard. It is the clinical practice guidelines, anticoagulation during cardiopulmonary bypass. So this is a great paper to dig into for this lecture. And in this paper, they actually show some evidence-based recommendations. Here's a couple of the Class 2A recommendations, and the first two here have to do with testing and diagnosing HIT, and that's important, and we talked about that in the HIT screencast. The third bullet point is for patients who are positive for HIT, it's reasonable to delay elective cardiac surgeries requiring bypass. But then the fourth point says, for patients with a diagnosis of HIT and in need of an urgent operation requiring cardiopulmonary bypass, anticoagulation with Bilvalirudin is a reasonable option, and that's a level of evidence B. So it's a Class 2A recommendation, level of evidence B. So we need to look at this alternative Bilvalirudin and see what it does and how it works. Bilvalirudin is a direct thrombin inhibitor. It interacts directly with thrombin to inhibit its action in cleaving fibrinogen to fibrin. And it really has its roots in the study of leeches. And leeches will attach themselves to your skin, and they're bloodsuckers. And their saliva produces an anticoagulant called a heparin, which keeps everything patent so that leech can have a clear access to your blood supply without it clotting. And so heparin, the Bilvalirudin is a recombinant version of heparin, and Bilvalirudin is a synthetic analog of heparin. It's a much smaller peptide, 20 amino acids versus 65, but it has all the active components of the heparin. So if we look at thrombin up in the upper left here, antithrombin 3, this has been potentiated by heparin. It binds to thrombin. Here's the active site, this active site in thrombin where antithrombin 3 can bind to it to inactivate it and make it less less of a procoagulant factor. So here's heparin bonding to AT, antithrombin, and this binds into the active site, and this domain, this heparin binding site on the side, which holds it in there nicely and keeps it as a stable complex. If you look at Bilvalirudin, it has a point which is a bivalent direct thrombin inhibitor, and it has a point which binds into the apolar site, and it also binds onto this fibrinogen binding site here. So it does its work in deactivating and inhibiting thrombin like this. We're also going to talk about argatroban, which is a univalent direct thrombin inhibitor, and it binds right in this apolar site right there. But let's spend some time with Bilvalirudin. And in the paper of the best practices paper that we discussed, it says, although several agents have been used as alternatives to heparin, there is only sufficient data on Bilvalirudin to make recommendations in the clinical setting. So this paper is only recommending Bilvalirudin. We'll talk about argatroban because it does have a number of publications associated with its use. But as far as evidence-based medicine, Bilvalirudin is the one to use. And so here's an example of a protocol. We would draw a baseline ACT. We have a goal of 2.5 times baseline. There's a bolus, 1 milligram per kilogram, followed by an infusion rate of 2.5 milligrams per kilogram per hour. We're going to throw another bonus 50 milligrams in the prime. So we kind of use it like we would use heparin. We give a bolus dose, we put some in our prime, and unlike heparin, we would have a continuous infusion. And we'll talk about reasons why, but it's because its half-life is so much shorter than heparin that we have to keep up with it by having a continuous infusion during the pump run. And this is an interesting note. The cell saver, other parts of the circuit where blood is collected but not directly circulating, should have sodium citrate added. And so one of the bottom lines with using any heparin alternative is to avoid stasis. Any place in the circuit where blood is not moving has to be either flushed continuously or periodically, or should have sodium citrate added to avoid clotting. So some of those recommendations: use a closed system whenever possible, so not an open hard shell reservoir, but a closed system. Use saline flushes in the veins instead of blood to avoid stasis. Run low blood levels in the venous reservoir to avoid stasis. Give cardioplegia every 15 minutes to maintain cardiopulmonary bypass line patency of the cardioplegia system. And flush blood-filled and clamped CPB lines every 15 minutes. So again, a little more concern about clotting in some of the tubing. When coming off bypass, stop Bilvalirudin 15 minutes and up to 60 minutes before the planned end of bypass. And so, unlike heparin, where we just keep the heparin and ACT levels high, we're actually going to discontinue, let that Bilvalirudin infusion stop prior to coming off bypass. And that's important because there is no reversal agent for Bival. Consider ultrafiltration 30 to 60 minutes prior to coming off. Bilvalirudin will cross the membrane of the ultrafilter. Once off bypass, move the arterial cannula to the right atrium to minimize the risk of stroke. Continuous ultrafiltration with ACT monitoring. Low-dose recombinant factor 7 may be a rescue option if bleeding is a problem. So here's a formal protocol for Bilvalirudin, and again, it has some of the similar elements of, if it's a bypass case, the patient gets that 1 milligram per kilogram bolus, 1 milligram per kilogram per hour, 2.5 milligrams per kilogram per hour during bypass, 50 in the pump. And again, some of the precautions: avoid stasis in the reservoir devices, replace cardiotomy suction by cell saver, And again, you'd use you would probably use citrate and a salt saver, I guess, in this instance. Because remember, the reason we're avoiding heparin is that causes untoward reactions to the patient. So that's Bilvalirudin as an alternate anticoagulation. Study these protocols a little bit and be familiar with some of the limitations. Again, the number one problem, you can't reverse it. Bleeding can be prolonged after bypass, and it can be a real problem. Is the controlling of hemostasis. Well, let's look at the other direct thrombin inhibitor, argatroban. Again, it operates a little differently. It's a very small synthetic non-peptide small molecular weight. It inhibits thrombin by means of a univalent binding to the active site. It's recommended in patients with renal failure. So, this is one time you may consider argatroban over Bilvalirudin, is if you had a patient who had who had a renal failure or kidney dysfunction, and because it's not cleared by the renal system, it's cleared by the liver. It has a longer half-life as well than the Bilvalirudin. 40 to 50 minutes, and so it has these advantages. It's the antigenicity of argatroban is good. The hepatic elimination versus renal elimination is good for those patients that have renal problems, which many of our cardiopulmonary bypass patients do. And it's a relatively short half-life, independent of renal elimination. So, 40 to 50 minutes isn't too long, and so it makes it a suitable alternative. And again, if we look at where argatroban falls in the direct thrombin inhibitors, you can see it's a much smaller synthetic non-peptide that binds right there to the active site. So again, getting back to our guidelines paper, a Class 2B recommendation, anticoagulation reversal when using heparin alternatives and direct thrombin inhibitors. For patients requiring anticoagulation with Bilvalirudin who have excessive bleeding after cardiopulmonary bypass, a combination of modified ultrafiltration, modified ultrafiltration, and 2, hemodialysis, and 3, administration of recombinant factor 7A with blood product replacement may be considered to improve hemostasis in these extreme situations. So they even have a recommendation surrounding the fact that this is hard to reverse and that bleeding can be a problem. Excessive bleeding can be a problem. And so here's the things that can be considered in that instance to help improve hemostasis, especially when bleeding is a big problem. So those are alternatives to heparin, but there are other possibilities, especially in the face of heparin-induced thrombocytopenia. And one of those is using platelet inhibitors. And one of those platelet inhibitors is iloprost. And what iloprost is an analog of prostacyclin. It's shown to act via the PGI2 platelet receptor as an inhibitor of platelet activation. So this analog of prostaglandin can inhibit platelet activation. And so there's a body of literature, and this is one of the more recent articles that show that you can use this in cardiac surgery with patients who have diagnosis of the immune HIT type 2, true HIT. They have reactive antibodies, and so they've used this to sort of anesthetize the platelets, to put the platelets asleep for the period that they're heparinized, so that they're not activating. And they make a few conclusions, and we'll look at those briefly. It allows cardiac surgery to be undertaken safely despite re-exposure to heparin. So using this, you can go ahead and once the iloprost is on board, you can give heparin. one of the problems with iloprost is that hypotension is a side effect, and so you have to be really attentive. If you use this on bypass, you really have to watch the blood pressure, and if you need it, you have to control it with norepinephrine infusions, neosynephrine, anything that can improve the vascular tone. But again, they couch their conclusions with, it's advisable, however, to postpone cardiac surgery whenever possible. So you need to be really careful with it regarding life-threatening hypotension as well. So again, we really appreciate heparin and the way it can be easily used and usually can quickly reversed. But we will be faced with these conditions where you have an urgent case of a patient who has hit antibodies and needs surgery immediately, and so we need to be prepared with some battle plan, some protocols to handle these types of patients. So I look forward to discussing this in class, and go ahead and dig into some of that material that's provided on Blackboard. Thank you very much. Take care.